Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently JR2 in the Department of Pharmacology, AIMS Kalyani, and I am back with one of my tutorial. So without wasting any time further, let's get into today's topic. So today's topic is basically pharmacokinetics for the BSc nursing students. So this video is basically targeting the BSc nursing students, but it can be also be seen by the MBBS students, BMLT students, and other paramedical courses. So what is pharmacokinetics? So pharmacokinetics is basically the study of the absorption, distribution, metabolism, and excretion of the drugs. That is basically the movement of the drugs into, that is inside the body, within the body, that is within the body, and out of the body. So what do we mean by this? Let's describe this definition. So there are four processes which are involved in pharmacokinetics, that is absorption of the drug. Suppose we are taking a drug by the oral route. Then you can see first absorption occurs, that is the drug enters into the systemic circulation. That is called as absorption. Following that, it is getting distributed to the different parts of the body. That is called as the distribution. Then after getting distributed, some of the drugs are getting metabolized in the liver, or it can be in the intestinal mucosa. That is called as metabolism. And following metabolism, the drug is excreted out of the body mainly via the kidneys and also via the biliary excretion or via the exhaled air. So that is called as the excretion of the drugs. So as you can see, when the drug is getting absorbed, so it is entering into the systemic circulation, then it travels in the body, that is distribution, that is within the body, and it is getting excreted out of the body, that is called as the excretion. So pharmacokinetics is basically the movement of the drugs into, within, and out of the body. So it is basically what the body does to the drug. As you can see, the drug is getting absorbed, then the body is metabolizing the drug with the help of the metabolizing enzyme, then the drug is getting excreted out of the body. And there is pharmacodynamics, in which the study is basically that what the drug does to the body. So in pharmacokinetics, what body does to the drug, and in pharmacodynamics, what is the drug going to do with the body. So this is about pharmacokinetics. So under this, we have four main processes, that is ADME, that is absorption, distribution, metabolism, and excretion. So for these processes, that is all these processes, absorption, distribution, metabolism, for this, the drug has to cross through various barriers. So suppose if it is to be excreted out of the body, that is via urine from the kidney, so it has to cross the glomerular basement membrane. Then suppose if it is to be absorbed from the intestine into the blood circulation, then it has to cross the intestinal epithelial cells. And for all these cells, we know they have a membrane which is called as the biological barrier, that is nothing but the cell membrane. So cell membrane, so drug has to travel through this cell membrane to enter into the cells, and then it is going to be transported to different parts of the body. So this cell membrane is actually made up of lipid bilayer, as you can see here, that is lipid bilayer, that is phospholipids. So phospholipids are basically the constituent of the cell membrane. So if a drug is lipid soluble, it can easily cross through this barrier, that is the cell membrane, and as a result, its process, that is absorption, distribution, everything will be very fast for it. So the general point is that for the transport of the drug to occur fast, it has to be lipid soluble in nature. Then only it can easily cross the plasma membrane, which is made up of phospholipid bilayer. Now coming to the different types of transport. So we have passive transport and we have active transport. So in passive transport, we don't require any energy, whereas in case of active transport, we require energy in the form of ATP. Under passive transport, we have the simple diffusion, that is passive diffusion, and then we have facilitated diffusion. In both these methods, there is movement of the drug from high concentration to low concentration. That is, the movement of the drug occurs according to the concentration gradient. Whereas in case of active transport, the movement occurs against the concentration gradient, that is from low concentration to high concentration, and as a result, we need energy. Now the difference between passive diffusion and facilitated diffusion is what? In passive diffusion, the drug can directly get diffused, so there is no involvement of any carrier protein. But in case of facilitated diffusion, the drug moves from a higher concentration to low concentration, but it requires a carrier protein. As you can see here in this image, if the drug is to be going by passive diffusion, then it can directly cross the membrane, but here the drug is being transferred with the help of this carrier protein. As example, we can see this is GLUT4, that is glucose transporter 4, which is helpful in transporting glucose in the muscle cells by allowing the glucose to pass through the cell membrane. So the glucose binds to the GLUT4 receptors, and then the glucose molecule is internalized into the muscle cell. So this is the way by which facilitated diffusion occurs, and in facilitated diffusion we need a carrier protein. Similarly, in active transport, we can take the same example, but here instead of the carrier protein, we will have a pump which is going to use the energy ATP, and it is going to transport the drug from lower concentration to higher concentration. That is against the concentration gradient. Active transport is further divided into primary active transport and secondary active transport. In primary active transport, there is movement of the drugs with the help of the expenditure of ATP. So with the help of the expenditure of ATP only, there is movement of one particular molecule. Whereas in case of secondary active transport, there is movement of two different molecules. For the movement of the first molecule, we need ATP, and the second molecule moves because of the movement of the first molecule itself. So basically, for the movement of the first molecule, we need ATP, and for the movement of the second molecule, we don't need the ATP. So under this secondary active transport, we have two different modes, that is two different types of secondary active transport. First is symport and the another one is antiport. So from the word it is very clear, in symport both the molecules are going to move in the same direction, and in case of antiport, one molecule is going to move in one particular direction and the other molecule is going to move in the other direction. So basically opposite direction of the movement of the molecules. So example of symport is Na plus Ka plus 2Cl minus symporter, which is present in the loop of Henle in the nephron. And example of antiport is Na plus H plus exchanger. That is, Na plus will be moving to one side and H plus will be moving to the other side. And this circle here indicates the pump, that is, which is the pump which is using ATP for the movement of the molecules. Now, example of the drugs which are being transported by this method, that is active transport, includes levodopa and iron. So levodopa is used for Parkinson's disease. That will be discussed in systemic pharmacology. So this is about the different types of transport. Now coming to one clinical application of this active transport, probenecid and penicillin. So these two drugs are usually given together because to increase the duration of action of penicillin. And how does it occur? Because these two drugs are excreted into the renal tubules by tubular secretion by the organic anion transporter 1. So when these two drugs are present together, these two drugs will compete for OAT1, and as a result, probenecid will be excreted into the renal tubule and penicillin's excretion in the renal tubule by the renal tubular excretion will not occur. As a result, this will increase the duration for which the penicillin is present in the body, leading to prolongation of the duration of action of penicillin. So this is basically the rationale for combining probenecid with penicillin, because both of them are being excreted by the same transporter, that is organic anion transporter 1 into the renal tubules, and since there is a competition, as a result, now the penicillin will not be excreted, and this will lead to increased presence of penicillin in the body for a longer duration of time, leading to prolongation of duration of action of the penicillin. Now let's discuss the different processes, that is absorption, distribution, metabolism and excretion. First is absorption. So absorption is nothing but the passage of the drug from the site of the administration into the systemic circulation. So in case of intravenous route, we are directly injecting the drug into the systemic circulation. So in case of intravenous route of administration, we will not have the absorption process. That is, the drug is bypassing the absorption because the drug is directly entering into the systemic circulation. Whereas in rest all routes, be it by oral route, be it subcutaneous, be it intramuscular, be it inhalation route, in every route, the drug is first transported into the systemic circulation, and then that's why there is a step of absorption for all other modes of administration. But in intravenous route, we don't have any absorption because the drug is directly entering into the bloodstream. Now in this image, you can see the different factors which are affecting the absorption of the drug. So it includes the disintegration time, the dissolution time of the drug, different formulation of the drug, the particle size of the drug, area of the absorbing surface of the drug, the lipid solubility of the drug, pH and ionization of the drug. Presence of other drugs will also affect the absorption of the drugs. Then gastrointestinal motility, then presence of food, then diseases which are affecting the gastrointestinal tract in case the drug is being taken by the oral route or by the enteral route, then vascularity of the absorbing surface, and suppose if the drug is getting metabolized even before it is getting absorbed, that is first pass metabolism, in that case also it is going to affect the absorption of the drugs. So these are the different parameters which are going to affect the absorption of the drugs. Now let us discuss all these parameters individually. So when we classify it into broad three categories, it will be included as pharmaceutical factors, then we have the drug factors, and then we have the biological factors. So pharmaceutical factors is basically including the disintegration time and the dissolution time, formulation which is being given on the particle size of the drug, whereas drug factors includes the inherent properties of the drug, like the lipid solubility of the drug, whether it is lipid soluble or whether it is non-lipid soluble. Like as I have already mentioned, the lipid soluble non-polar drugs and non-ionized drugs are easily transferring, that is easily transporting across the cell membranes. As a result, the distribution and absorption will be fast for them, whereas in case of ionized drugs, it will not be transporting easily from the lipid bilayer. As a result, their absorption distribution will be slower compared to those which are lipid soluble. Then we have the pH and ionization, because it determines the ionization status of the drug. That is, pH means the pH of the medium in which the drug is present, and ionization means the ionization status of the drug. Then biological factors, it includes the area and vascularity of the absorbing surface. That is basically it. Here we are going to discuss about the small intestine, why the drug absorption is better in small intestine. Then we have GI motility, which will also affect the absorption of the drug. Presence of the food will also affect the absorption of the drug. Diseases and first pass metabolism. So all these are coming under the biological factors which are affecting the absorption of the drug when it is given via the enteral route. Now coming to the first one, that is the pharmaceutical factors. So under this we have disintegration and dissolution time. So what do we mean by disintegration? Whenever a drug is taken orally, it has to be first broken down into individual particles. Okay, small individual particles. Suppose if we are taking a tablet, it has to be broken down into small individual particles, and this process is called as disintegration. So disintegration will affect the absorption process, and then these particles has to get absorbed into the solution. So this disintegration process and dissolution process affects the absorption, and that is the reason why liquids are absorbed faster than the solids. Because in case, suppose if we take a solid, that is example in the form of tablet, first it has to disintegrate, then these particles has to be dissolved into the medium in which it is present, for example the gastrointestinal fluids. So these are the molecules and this is the gastrointestinal fluid. So these two process occurs in case of solid form, but whenever we take a liquid form, this disintegration process is skipped because it is already in liquid form, and also it is dissolved in the liquid. So the dissolution process is also skipped. As a result, when we take liquids, they are absorbed faster compared to the solids. So this is because of the absence of disintegration and dissolution in case of liquids, which is present in case of the solid dosage forms like tablet, be it tablets or be it capsules. So in that case. Now coming to the next factor, that is formulation. In a drug, apart from the main principal ingredient, that is API, that is active pharmaceutical ingredient, apart from the active pharmaceutical ingredient which produces the major effect of the drug, there are several other constituents also, like the binding agents, which is responsible for maintaining the shape of the particular tablet or the capsule. So these binding agents will affect the absorption. The example is inert substance which are used in drugs, such as we have the starch and lactose. This will affect the absorption, interfere with the absorption, and it will decrease the absorption. Whereas there are some other constituents also, the constituents which attracts water. Okay, so if it attracts water, it means it is getting dissolved into the liquid easily, and as a result it will increase the rate of absorption. So this is the role of the different constituents of a particular formulation, and as a result this will affect the absorption. Either it can increase the rate of absorption or it can decrease the rate of absorption. Then we have particle size. So smaller is the particle size, faster is the absorption. It is very common, that is small particles are absorbed faster than the larger particles. And reason for this, we can also see that suppose if we have an absorbing surface, and suppose if we have a drug which is having small particles, so almost all the particle, that is the entire area of the particle, is in contact with the absorbing surface. Whereas if we have larger particles, that is large drugs with larger molecules, then in that case we can see only a small part of it is in contact with the absorbing surface, and as a result, for a drug for which we want it has to be staying in the intestine. Like suppose if we want to treat an infection which is present within the lumen of intestine, in that case we will consider the drugs which are having a larger molecular size, that is larger particle size. So in that case it will be absorbed less from the intestine, and we will get the effect directly in the intestine. Whereas if we want the drug to be absorbed very fastly from the intestine, we need to make the drugs in such a way that the particle size and the molecular size is less, so that it is absorbed faster. Now coming to the drug factors. So under drug factors we have lipid solubility, that is If the drug is lipid soluble, it is absorbed faster because it can easily penetrate through the lipid bilayer, that is phospholipid bilayer. Next is pH and ionization. Okay, so most of the drugs which we take are usually weak electrolytes, so their ionization will depend upon the pH of the medium. And how do we explain this? Let's focus on this image. Suppose in stomach we have HCl. So as a result, the pH of the stomach will be acidic in nature. So if we take weakly acidic drugs, that is weak electrolytes, this weak electrolytes example we have barbiturates will remain in the unionized form in acidic pH, and as a result it will be easily absorbed because, as I've already mentioned, when the drug is unionized, non-polar and lipid soluble in nature, it is easily absorbed. So general dictum is that whenever a weakly acidic drug is present in an acidic medium, it will be absorbed easily, whereas when a weakly basic drug is present in a basic medium, it will be absorbed easily, because in both the cases, when the medium of the drug, that is pH of the medium and the pH of the drug, are almost the same, in that case it will not be in ionized form, it will be in unionized form, and as a result they will be absorbed better. Whereas if we want the drug to be excreted, in that case we will have the pH of the drug which is just the opposite of the pH of the medium. Suppose if we want a drug to be excreted easily and the drug is acidic in nature, so in that case we will have to alkalinize the urine, whereas if the drug is alkaline or basic in nature, in that case we will have to acidify the urine, because in that case, when the pH of the medium and the pH of the drug are different, in that case the drug will be in ionized form, and hence, since it is not getting absorbed, it is going to be excreted out of the urine because it is more polar in nature and more water soluble rather than being lipid soluble. So in case of the drugs like morphine and amphetamine, which are weakly basic drugs, they will be remaining in unionized form in small intestine, because in small intestine we are having alkaline pH, whereas in case of stomach we have the acidic pH. So these drugs will be better absorbed for small intestine. But overall, when we take into consideration maximum absorption of any drug which is given by the enteral route, it is always maximum from the small intestine. Even though if it is a weakly acidic drug, still its maximum absorption will be from small intestine. And what is the reason behind that? We will be coming into that in the upcoming slides. And this degree of ionization based on the pH of the medium for weak electrolytes is explained by the Henderson-Hasselbalch equation. So you can just remember that this equation is the one which is correlating the degree of ionization with the pH of the medium. And drugs which are strong acid and bases are always highly ionized, and hence they are always poorly absorbed. And it doesn't depend on the pH of the medium in which the drug is present. Always they are going to be in polar state, that is in ionized form, and hence their absorption will be less. Now, why is it that maximum absorption occurs mainly from small intestine when the drug is given by the enteral route? So the reason why the absorption of all the drugs when taken by oral route is maximum from small intestine is because the absorption area, that is the area which is responsible for absorbing the drugs, and the vascularity is high in case of small intestine. Why is it so? Because in small intestine we have villi, which increases the total surface area of absorption, and this is the reason why even if the drug is weakly acidic or weakly basic, always the maximum absorption occurs from small intestine and not from the stomach, because in stomach we don't have the features, that is villi, which is going to increase the area of absorption. Next factor is gastrointestinal motility. Under that we have two important factors, that is gastric emptying time and intestinal motility. So gastric emptying is basically the time by which the food is being transferred from the stomach to small intestine. So if it is fast, that is gastric emptying is fast and the gastric emptying time is low, that is if it is fast, the time will be less. So in that case the food will directly reach from the stomach into the small intestine faster, and as a result we know the absorption is faster from small intestine because of its high vascularity and large surface area. So in that case the absorption will be faster. So absorption is faster when the gastric emptying time is less. Next, intestinal motility. When the intestinal motility is high, that is in case of conditions like diarrhea, so in that case the drug molecules will not be in constant contact with the absorbing surface, as you can see here, because of the increase in the intestinal motility, and as a result this will lead to decrease in the absorption. So it slowers the absorption if the intestinal motility is high. Next is the presence of the food. So drugs may form complexes with the food constituents. Such complexes are not absorbed easily, and as a result, because of the presence of the food, the absorption decreases, which is a general dictum. Like tetracycline, it chelates with the calcium which is present in the food, and as a result the absorption is decreased. But there are some drugs like griseofulvin, then we have posaconazole and several other drugs also whose absorption is increased in the presence of food and basically the fatty food. So this is an exception to the general dictum. Next, we have the diseases of the gastrointestinal tract. So suppose if we have malabsorption syndrome and suppose if we have achlorhydria, that is decrease in the HCl production by the stomach. In that case, the drug will not be absorbed properly, and as a result, this decreases the absorption of the drugs. So diseases which are affecting the gastrointestinal tract will also affect the absorption of the drugs. Now coming to the 10th point, that is the first pass metabolism. So what is first pass metabolism? First pass metabolism is nothing but the metabolism of the drug during its passage from the site of absorption to the systemic circulation. Okay, so even before the drug is reaching the systemic circulation, it is getting metabolized. So as you can see, the drug is present in the stomach, then it reaches the small intestine. From there, by the enterohepatic circulation, it reaches the liver, and there some of the drugs is getting metabolized even before it is entering into the systemic circulation. So this is called as the first pass metabolism, which is also called as the first pass effect or the pre-systemic metabolism. So suppose if the drug is having partial first pass metabolism, in that case what we have to do, we will have to increase the dose of the drug, because the amount of the drug which is reaching the systemic circulation will be less than what we are expecting, because most of the drugs are getting metabolized in the liver. So for the drugs like propranolol, we have to increase the dose. And suppose if the first pass metabolism is very high for some of the drugs, example insulin, in that case we need to change the route. That is, instead of giving the drug by oral route, here in insulin we are giving by subcutaneous route. In case of emergencies like diabetic ketoacidosis, in that case we can give by IV route also, because in that case what happens is it will bypass this first pass metabolism which is present in the liver, which occurs in the liver, and directly the drug will enter into the systemic circulation. So drugs given orally may be metabolized in the gut wall and in the liver also before reaching the systemic circulation, and that is what we call as first pass metabolism or pre-systemic elimination, pre-systemic metabolism or first pass effect. So this is also going to affect the absorption of the drug. Now, absorption of the drug when it is given by the parenteral routes. So parenteral route means any route which is different from the enteral route. So in enteral route, the drug has to go through the gastrointestinal tract. So if we give a drug by parenteral route, so in parenteral route we include several routes of administration, that is intravenous route of administration, then intramuscular route of administration, subcutaneous route of administration, then topical application, then through the inhalation route also. So in intravenous route of administration, since the drug directly enters into the systemic circulation, absorption is maximum. Actually the absorption process is only skipped, drug directly enters into the systemic circulation. And in intramuscular route, the comparatively absorption will be less from the intravenous route, and the absorption will be even further less in case of subcutaneous route. This is because the muscles are having comparatively high blood supply than the subcutaneous tissue. As a result, it will be absorbed faster from the intramuscular route than the subcutaneous route. And then we have the inhalation route. In inhalation route also, the drugs will be absorbed faster. If it is lipid soluble inhaled drugs, it will be absorbed faster even than the intramuscular route, because the lung is having an increased vascularity, plus it is also having a large surface area for absorption. So there will be better absorption in case of inhalation route. And then when we give the drug by the topical route, it is absorbed faster when the skin is abraded, because if the skin is present intact, then in that case we will have several layers of the skin. That layers of the skin will have several cells which are tightly packed, multiple layers. So this will actually impede the transport of the drugs. But whenever it is actually abraded, some of the layers will be missing, like epidermis will be missing. In that case, the drug will be transported and absorbed faster. And when the drug is applied directly on the mucous membrane, in that case drug will be absorbed even better than that when it is absorbed by the abraded skin or by the skin. So these are the different parenteral routes. Now coming to the concept of bioavailability. So bioavailability means the fraction of the drug that reaches the systemic circulation following the administration of the drug by any route. Like suppose if we are giving a drug by the oral route, let it be some 500 milligram, it is not that 500 milligram of the drug is going to reach the systemic circulation. A fraction of it is only going to reach into the systemic circulation, because some of them will not be absorbed, some of the drugs will be metabolized, some of the drugs will be redistributed or distributed to different parts. So the fraction of the drug which is reaching unchanged in the systemic circulation via any route of administration is called as bioavailability. And that is the reason why bioavailability is 100% in case the drug is given by intravenous route, because here the drug is directly entering into the systemic circulation. So 100% of the drug is available in the systemic circulation. And the factors, the 10 factors which I have discussed so far, which are affecting absorption, these are only going to affect the bioavailability also. So the factors affecting the absorption will also affect the factors affecting the bioavailability. And bioavailability of the drugs will be less in case of intramuscular and subcutaneous route compared to that of the intravenous route, but here the bioavailability more compared to the oral route, because in oral route there can be incomplete absorption of the drug and there will be first pass metabolism which can be skipped in case of intramuscular and subcutaneous route to some extent. Now coming to bioequivalence. So bioequivalence is basically comparison of bioavailability of the different formulations of the same drug. That is, suppose if we have a particular drug that is paracetamol, there are different manufacturers for paracetamol, and so hence there will be different oral formulations of the paracetamol. Suppose the two different formulations will lead to same bioavailability. In that case, what we can say, those two formulations are bioequivalent. Whereas suppose if the other constituents of the drug, like the inert substance, be it the binding agents, lead to different rate of disintegration and dissolution, in that case two different formulations of the same drug will not be called as bioequivalent, because their bioavailability will change because of different rate of disintegration and dissolution. So here is an important point. Suppose if a drug we know has a low safety margin, like we have drugs like digoxin. So in that case, what we have to do is, suppose a patient is actually acclimatized to a particular brand, then we have to continue giving the drugs that is from the same brand itself, because if we change the brand, it might lead to change in the bioavailability, and this can lead to either toxicity or it can either lead to failure of the treatment. So we have to continue with the same brand. And here in this image you can see the study of the bioequivalence. So P, Q and R are the three different formulations of the same drug. Okay, and here you can see in formulation R, it is not even reaching the therapeutic concentration, that is the bioavailability is so less. And P, for that formulation, it is crossing the therapeutic concentration, and Q is crossing the therapeutic concentration for a short duration of time. So this is the reason why we need to do bioequivalence study. That is, whenever the drugs are bioequivalent, their bioavailability will be comparable, almost same. And whenever the drugs are not bioequivalent, then their bioavailability will be differing drastically. Now coming to the next process of the pharmacokinetics, that is absorption is already over for us. So now we have distribution. So from the systemic circulation, that is absorption, the drug will be distributed to various tissues. So this process is called as distribution. And for distribution also, as I have already mentioned, the general dictum, if the drug is non-polar, non-ionized and lipid soluble, it will be easily absorbed and it will be easily distributed because it can easily cross the phospholipid bilayer. So the factors which are affecting the distribution, first is lipid solubility of the drug. So if the drug is more lipid soluble, it will be easily distributed. Next is ionization status of the drug. Suppose if the drug is more ionized, it means it is polar and it is less lipid soluble, it is more water soluble. In that case also distribution will be slow. Then blood flow. Suppose the blood flow to a particular area is more. So in that case the distribution occurs faster, because more blood flow means more drug reaching that particular area. Next parameter is binding to the plasma proteins like albumin. So suppose the drug is bound to the plasma protein. In that case, this bound form of the drug will not be able to come out of the vasculature because it is bound to a protein. Only the free form of the drug is being able to come out of the vasculature. So if there is increased plasma protein binding, in that case also there will be decrease in the distribution of the drug, because most of the drug will remain isolated in the vasculature only because it is bound to the protein. So only the free form of the drug will be coming out of the vasculature and will reach to the different sites of the body. So now coming to the significance of the plasma protein binding, as you can see, drugs after reaching the circulation binds to the plasma proteins. Okay, so acidic drugs, they will bind to albumin, and basic drugs, they will bind to alpha acid glycoprotein, and the rest will remain in the unbound form, that is the free form, and this is the form which is responsible for mediating the action of the drug. This fraction of the drug is responsible for mediating the action of the drug. This fraction of the drug is the only drug which is going to get metabolized and also going to get excreted, and bound form is basically acting as a reservoir. So once the unbound form is used up, then some of the drugs which are present in the bound form will turn into the free form. So basically the bound form of drugs act as the reservoir. So So as you can see here, this protein binding serves as a reservoir for the drug, and as a result it will prolong the duration of the action, because earlier the free form, suppose if the drug is only present in the free form, so once it is being used up, there is no reservoir for producing new free drugs, no. So if we have the reservoir, after the free drugs is being used, those bound form of the drugs will be converted into the free form of the drugs, and as a result there will be increase in the duration of action. Then one interesting thing which occurs considering the plasma protein binding is the displacement reaction. Suppose we have two different drugs, example, let's take an example of warfarin and indomethacin, both of which bind to the same site of the plasma protein, that is same plasma protein, let it be albumin. So in that case, when these two drugs are given together, then they will compete against each other for binding to the same plasma protein, and as a result, suppose this drug, that is warfarin, which was initially highly plasma protein bound, now some of the areas will be bound by indomethacin, and as a result some of the warfarin which was actually supposed to be present in the bound form will convert into the free form. So this will lead to toxicity of warfarin, because the portion of the drug which we were thinking will be present in the free form is now more than what we have expected, because some of the areas of the plasma protein binding is being occupied by indomethacin. So that is basically indomethacin has displaced warfarin from its binding site in the plasma protein, leading to toxicity of the drugs. Then in conditions where we have low albumin, like in case of malnutrition, then in case of chronic renal failure where we have albuminuria, in case of chronic liver disease where there is decreased production of the albumin, in that case there will be decreased plasma protein binding because the proteins are less, so less plasma protein binding, and as a result, in that case, whenever we are giving the drug, we have to modify the dose, because now the free form of the drug will be more. So if we are not modifying the dose, that is decreasing the dose, then it can lead to toxicity also. Then next factor is some of the inflammatory conditions, that is myocardial infarction. In that case, there will be increase in some of the proteins, that is the positive acute phase reactants, and as a result the protein binding, that is plasma protein binding for the drugs, will increase because the proteins are increasing. So in that case we will have to increase the dose of the drug because the free form of the drug will be less. So this is about plasma protein binding, and some of the highly plasma protein bound drugs includes warfarin, then we have diazepam, then we have phenytoin, then we have sulfonamides. So diazepam and phenytoin are basically anti-epileptics. And now coming to the next type of binding, that is called as tissue binding. That is, some of the drugs are getting bound to certain tissues because they have a specific affinity for that, and whenever there is increased binding, be it plasma protein binding or be it tissue binding, this will cause the prolongation of the duration of the action. Why? Because they will serve as a reservoir for the drug. Once the free drug is being used, then the bound drug will convert into the free drug, and as a result it will lead to the prolongation of the duration of action. So the different tissues for which the different drugs are having affinity, for example, we have adipose tissue, for which the drug which binds to adipose tissue mainly includes the benzodiazepine and thiopentone sodium. For muscles, we have emetin. Then to bone, the drugs like tetracycline and lead binds. Then to retina, chloroquine, which is an antimalarial drug, and to thyroid, iodine. And when there is increased binding of chloroquine to retina because of its affinity to retina, it can also lead to some of the adverse effect, that is the bullseye maculopathy. So that is actually a result of increased affinity of chloroquine to retina. Now coming to the next topic, that is redistribution. Like, it is a part of distribution process, and following distribution, metabolism occurs, but before that there is also a step of redistribution. So whenever a drug is highly lipid soluble in nature, so what happens is it gets easily absorbed into the systemic circulation. From there it goes to the organs like brain, heart and kidney very fastly, because they are highly perfused in nature. And after some time, since these are highly lipid soluble in nature, from there they will go to the less perfused organs like skin and subcutaneous tissue like muscle, fat, because they are less perfused. And then because of this, there will be termination of the action of the drug, because earlier the drug has reached the brain or be it heart or be it the kidneys very fastly, so there is onset of action of the drug is very fast, and after that the duration of action will also decrease, because now the drug has traveled from those highly perfused organs to the less perfused organs. So one example is anesthetic thiopental sodium. So this gets absorbed fastly and distributed to its target site, and from there it gets redistributed because it is highly lipid soluble, and as a result there will be termination of action within 5 to 15 minutes because of redistribution. Now, a small description about the different barriers, that is the blood-brain barrier and then we have the placenta barrier. So both these barriers, it is basically made up of cells. So in that case, we will have cell membrane. As a result, only the lipid-soluble drugs, which are unionized and non-polar in nature, will easily cross this barrier, whereas the ionized drugs will not cross this barrier and will not be able to penetrate through this barrier. So this is about the blood-brain barrier and the placental barrier. Now coming to the next point, that is the next entity. Basically, it is called as the apparent volume of distribution. So what is apparent volume of distribution? It is very important. It is defined as the hypothetical volume of the body fluid into which a drug is uniformly distributed at a concentration which is equal to that in the plasma, assuming that the body is a single compartment. So here the keywords are hypothetical volume, uniformly distributed, and the concentration should be equal to the concentration of the drug in the plasma, and the whole body is considered as a single compartment. Because the reason for having this apparent volume of distribution is that because it is imaginary volume. Whenever we actually measure the concentration of the drug, we can measure the concentration of the drug from the plasma and some other fluids only, not from the other organs like heart or from lungs. So in that case, when we get the concentration of the drug in the plasma, then we will take this concentration of the drug, like we know this concentration of the drug and we know the total amount of the drug also. So when we divide these two entities, we will find an imaginary volume in which the drug will be distributed in the same concentration as it was present in the plasma. And that is what we call as apparent volume of distribution. And it is called as apparent because it is not a real entity. It is an imaginary volume in which the drug is being distributed uniformly in the same concentration as it is present in the plasma. So this is called as apparent volume of distribution. So whenever the apparent volume of distribution is high, it means the drug is more distributed. That is, it is distributed more into the body. So it will be more in the extravascular area. Whereas if the drug is having a low volume of distribution, it means the drug is mainly concentrated into the systemic circulation and it is less distributed into the body. So drugs with high molecular weight like heparin or the drugs which are extensively bound to the protein, that is plasma protein like warfarin, are largely restricted to vascular compartment because it is bound to the protein, and if it is larger in size it cannot come out of the vasculature. In that case, AVD, that is apparent volume of distribution, will be low. And the drugs which accumulate in different tissues, like which have different affinity for different tissue, as in case of chloroquine which has got affinity for retina, it is present more in the tissues. It means it will have a higher apparent volume of distribution. And whenever a drug is having a large apparent volume of distribution, it means most of the drugs is present in the body tissues rather than being present in the systemic circulation. So in that case, suppose we have toxicity from that particular drug which is having a higher volume of distribution, their hemodialysis will be of no use for managing the poisoning, because in hemodialysis we are going to remove the drugs only from the systemic circulation, right? And in case the drug is having a higher apparent volume of distribution, so maximum drug will be present outside the blood, so there is no point of doing hemodialysis in that case. So hemodialysis is of no use of for removal of the drugs and poisoning if it is a drug which is having a large volume of distribution, that is large apparent volume of distribution. And fat to lean body mass ratio, suppose the fat is more and there are drugs which are mostly having an affinity towards this adipose tissue. In that case, the apparent volume of distribution will increase if the individual is having more adipose tissue or more fat. So that is basically about the fat lean body mass ratio. Now coming to the third process in pharmacokinetics, that is metabolism, which is also known as biotransformation. So it is the process of biochemical alteration of the drug in the body. The main site is liver and the other sites include kidney, gut mucosa, lungs, etc. So what is the main purpose of metabolism? That is to make the drugs polar and water soluble, that is ionized, polar and water soluble, so that they can be easily excreted through urine via kidneys. So this is the major purpose of metabolism, but there are exceptions to this also. And in metabolism, basically the drug is being inactivated and it is converted into a water soluble form so that it can be easily excreted out of the body. But there are exceptions to it. We will be coming to it later. So as you can see in this image, the drug which was earlier lipid soluble, that is hydrophobic in nature, is being converted into hydrophilic form by the process of biotransformation, and then it is being excreted either by the kidneys or via the bile. Also, some cases the drugs get excreted unchanged, that is without undergoing any metabolism. So example of such drugs include atenolol and furosemide, that is they are not getting undergoing any biotransformation, they are excreted as such. So this is the major purpose of metabolism. Now coming to the different outcomes of metabolism. So here we will discuss about the exceptions. So first, the common thing, that is active drug is converted into inactive metabolite. Example is morphine. So this is the normal thing. Then active drug can be converted into active metabolite also. Example, we have digitoxin which is being converted into digoxin. So here digoxin and digitoxin both are active in nature and both will have their effects. And then we have diazepam being converted into oxazepam. Both these drugs are having the anti-epileptic property. And now finally coming to the exception, that is the prodrug. So prodrug is basically an inactive drug, and it, when undergoes metabolism, gets converted into an active metabolite which is responsible for producing the particular effect of the drug. So prodrug will only show its effect only if it gets metabolized by the metabolizing enzymes. So example of prodrug is levodopa, which is being converted into dopamine, and dopamine is responsible for producing the effect, and it is used in case of Parkinson's disease. Then we have enalapril, which is converted into the active metabolite, that is enalaprelate, which is responsible for lowering the blood pressure. So it is used in hypertension, that is as an antihypertensive. So enalapril and levodopa, these are examples of prodrug. Now coming to the phases of biotransformation. So basically in biotransformation we are having two phases, that is phase 1 and phase 2. So the purpose of phase 1, as I have already mentioned, is inactivation of the drug. An exception to this is product, because product is inactive, it will be converted into active form. Then after the inactivation is done, the water solubility of the drug has to be increased, then only it can be excreted in the urine, right? So in phase 2 what happens is the phase 1 product is being converted into a more water soluble form by conjugation, that is by adding some of the functional groups to it. So we have several reactions under phase 1 and phase 2, and these are catalyzed by the enzymes which are called as xenobiotic metabolizing enzyme. This is because these enzymes metabolize the drugs also, and these enzymes metabolize any other foreign material, be it air pollutants, be it water pollutants, which are entering inside the body. So anything foreign to the body is called as xenobiotic. So these enzymes are called as xenobiotic metabolizing enzymes, and most of the phase 1 enzymes are microsomal enzymes, and they are actually responsible for carrying out several reactions. We will be discussing that. Out of that, the most common phase 1 reaction is oxidation, and then we have the phase 2 enzymes which are actually responsible for causing the which are actually responsible for increasing the water solubility of the drug. And here mainly we have non-microsomal enzymes which are mediating these reactions. One exception is the UDP glucuronosyl transferases. So this is actually a microsomal enzyme. So the most common phase 2 reaction is glucuronidation. So here you can see there are different types of phase 2 reaction. We have addition of sulfate, that is sulfation, then addition of glucuronic acid, that is glucuronidation, addition of glutathione, that is glutathionation, addition of acetyl group, that is acetylation, addition of methyl group, that is methylation. And for every group we are having different enzymes. For sulfation we have the enzyme which causes the sulfation, that is sulfotransferase. For glucuronidation we have UDP glucuronosyl transferases. For glutathionation we have glutathione S transferase. For acetylation we have N-acetyl transferase. For methylation we have methyl transferases. And cytochrome enzyme, that is cytochrome P450 enzyme, which are the microsomal enzymes that is responsible for mediating the phase 1 reactions. Apart from that we have other enzymes also, like flavin containing monooxygenases and epoxide hydroxylases, which are not that important. The main thing is the CYP450 group of enzymes. Now coming to this mnemonic, that is ORCHARD and GAMS, that is the different phase 1 reactions and the phase 2 reactions. So first, phase 1 reaction. So O stands for oxidation. It is seen in case of drug like phenytoin. Then R stands for reduction, seen in case of drugs like chloramphenicol. C stands for cyclization, that is cyclization of a compound. Then H stands for hydrolysis in case of drugs like procaine. Then A stands for aliphatic hydroxylation and aromatic hydroxylation. So aliphatic hydroxylation is seen in case of the drugs like ibuprofen, and aromatic hydroxylation is seen in case of the drugs like phenytoin. Then we have D, that is deamination for the drugs like diazepam. So ORCHARD. Orchard is basically the mnemonic for the different phase 1 reactions. Next is for phase 2 reactions, we have the mnemonic that is GAMS. So G stands for glucuronidation, which is seen in case of morphine. Glutathione, which is seen in case of paracetamol, which is very important. We need to know this because this is going to play a role in paracetamol poisoning also. Next is acetylation in case of isoniazid, which is an anti-tubercular drug. Then methylation for adrenaline, sulfation for steroids. So these are the different phase 1 and phase 2 reactions and the examples of the drugs which are being undergoing the particular phase 1 reaction and the phase 2 reaction. Now coming to the concept of enzyme induction and enzyme inhibition. So as we have already discussed that the drugs are being metabolized by the xenobiotic metabolizing enzymes. So these enzymes can be either induced, that is it can be either stimulated, so the activity of enzyme will increase, or it can be that there is a drug which leads to increase in the production of these enzymes. So in both the cases what we say is it is causing enzyme induction, because enzyme induction means either the production of the microsomal enzyme will increase or the stimulation of the microsomal enzyme will occur, leading to faster metabolism and increased metabolism of the drugs. And there are several drugs which act as these enzyme inducers. Then we have enzyme inhibition. It is just the opposite of enzyme induction. That is, here some of the drugs will cause the inhibition of the microsomal enzymes. As a result, it will decrease the metabolism of the drugs. So enzyme induction and enzyme inhibition. And because of these, that is enzyme induction and enzyme inhibition, the drugs which act as enzyme inducers and enzyme inhibitors, it will lead to therapeutic failure and drug toxicity. Therapeutic failure will occur in case we give enzyme inducer, because if we give enzyme inhibitor, so active drug is getting metabolized into inactive form and we will not get the desired response if it is occurring very fast. Then if we are giving enzyme inhibitor, in that case the metabolism of the drug doesn't occur, and as a result it will be accumulated in the body and it will cause toxicity. So these are the reasons which are responsible for causing the therapeutic failure and also the drug toxicity. Now coming to the examples. So examples of enzyme inducers, you can remember it by GPRS cell phone. So G stands for cresofulvin, P stands for phenytoin, R stands for rifampicin, S stands for smoking. Smoking can also cause induction of the enzyme. Then C stands for carbamazepine and P stands for phenobarbital, as you can see here. So this is the expansion of the mnemonic for enzyme inducers. Then we have enzyme inhibitors. For that we have mnemonic that is vitamin K cannot cause enzyme inhibition. So V for valproate, K for ketoconazole, C for cimetidine, E for erythromycin, and C is also for ciprofloxacin, then I for isoniazid. So these are the enzyme inhibitors. Now one clinical application which we can see here is, suppose if a female is having tuberculosis and the female was on oral contraceptive pill, okay, OCP is oral contraceptive pill. So we know rifampicin is the anti-tubercular drug. So if we give the anti-tubercular treatment to that particular patient and the dose of OCP remains the same, like the thing which was being given before the rifampicin was started. So in that case, what will happen? This rifampicin will induce the enzyme and this will lead to faster metabolism of OCP. And as a result, where we were expecting the contraceptive effect of the OCP, it will not be seen because it is being metabolized very fast because of the enzyme induction by rifampicin. So this is one example where enzyme inducer leads to drug failure, that is OCP failure. Now coming to the clinical importance of microsomal enzyme induction. One I have already mentioned. So as you can see, OCP failure occurs in case the patient is taking rifampicin, because rifampicin is an enzyme inducer. Then rifampicin being an enzyme inducer, it is going to metabolize paracetamol and it will form the toxic metabolite of paracetamol more, and this will lead to paracetamol poisoning. Then suppose we have a drug that is carbamazepine. What it does is it is an enzyme inducer and it induces the enzyme which is responsible for its self metabolism. So this is what we call as autoinduction, and as a result it leads to a phenomenon called as tolerance. That is, earlier at a particular dose we were getting the effect of carbamazepine, but now since it is getting metabolized because of its self-induction process, that is autoinduction process, now at a particular dose where we were getting the effect earlier, now we will not get the effect in that dose. We will have to increase the dose of carbamazepine. So that is called as tolerance, which occurs because of autoinduction caused by carbamazepine. Next, we can also use this phenomenon for treating neonatal jaundice also. As we know, in case of neonates, the conjugation of bilirubin occurs comparatively slowly because the enzymes are not that active. So if we give an enzyme inducer like phenobarbital, which induces the enzyme responsible for conjugation of bilirubin, so what it will do is it will increase the conjugation of bilirubin, and as a result the jaundice will get cleared in the neonate. So this can be used in the treatment of neonatal jaundice. So basically we are using microsomal enzyme inducer as a treatment for the treatment of this neonatal jaundice, where the bilirubin can be easily conjugated. Then coming to the different factors which are affecting the metabolism, first is genetic variation. As we know, different individual is having different genetic makeup, and this will lead to formation of differently active metabolizing enzymes. One example is defective pseudocolin esterase. So in individuals who are having defective pseudocolin esterase because of the genetic mutation, it will lead to succinylcholine apnea. So succinylcholine is basically a drug which is actually a muscle relaxant. So it will cause the paralysis of the muscles of the respiration. So if we have defective pseudocolin esterase in that particular individual, then this succinylcholine will not be metabolized easily and it will be present for a longer duration. So this will lead to respiratory paralysis, leading to apnea, that is shortness of breath. Then we have environmental pollutants like smoke. As I've already mentioned, smoke is an enzyme inducer, so it will lead to finally affecting the metabolism. Then we have diseases of liver and extremes of age. So in diseases of liver, the metabolizing enzymes are mainly present in the liver, as we know, that is microsomal enzymes. So they will act slowly, and at extremes of age, be it in the neonatal period or be it in the elderhood, the enzymes are acting slowly because they have lost their power. So in both the cases, what happens is there will be accumulation of the drug, leading to decreased metabolism of the drug, leading to accumulation of the drugs, and leading to increased chance of toxicity. So in such cases, when the individual is having diseases of the liver, or if the individual belongs to extremes of age, then we might have to decrease the dose of the drug, that is from normal dosing. Now coming to the last process in pharmacokinetics, that is excretion. So the most common organ which is involved in excretion is kidney. There are three processes which occurs in kidney. One is glomerular filtration, which will actually promote the drug excretion. Then we have active tubular secretion, that is active tubular secretion of the drugs into the renal tubules, which will also promote excretion. And we have passive tubular reabsorption, which is going to inhibit the excretion, because from the tubules, suppose if the drug is getting absorbed back into the plasma, so then in that case it will lead to decrease in the excretion. So this is an inhibiting factor for excretion of the drugs. Now what is the principle for excretion of the drugs? It is the same as it was for absorption and distribution, taking into Henderson-Hasselbalch equation into consideration. That is, if a drug, that is weakly acidic drug, is present in the acidic medium, it is more in the non-polar state. So in case of excretion, what we want the drug to be ionized, and it has to be polar so that it can be easily absorbed in the water soluble. So for acidic drugs, suppose if we have a poisoning of acidic drugs like salicylate and barbiturates, in that case what we have to do is we will have to make the urine alkaline in nature, so that the acidic drug gets converted into the ionized form, and as a result it will become polar and water soluble, so it will be easily excreted out. So what is that process called as? This process is called as forced alkaline diuresis. That is, here we have to give IV fluids which will cause the pressure. Then we have sodium bicarbonate which will alkalinize the urine, and diuretics, that is diuretics has to be given which will cause diuresis. So this togetherly is called as forced alkaline diuresis. And similarly, if we have poisoning by the alkaline drugs like quinine and amphetamine, then in that case we will have to acidify the urine. So there we do forced acidic diuresis, that is diuretics has to be given. Forced, that is it means IV fluid has to be given. Then to acidify the urine we have to give vitamin C, that is ascorbic acid. So as a result, the weakly basic drugs will be excreted out. Coming to the other routes of excretion. So first we have fecal and biliary excretion. So the drugs which are excreted by this route includes chloramphenicol, tetracycline, oral contraceptive pill. So fecal route. So by fecal route I mean the drugs which are given orally and are not absorbed properly from the intestine, they will be excreted by the fecal route. And also biliary excretion means the drug which are being excreted from the bile. So for this biliary excretion, one important term which will come into play is enterohepatic cycling. That is, when the drug is given orally, it reaches the gastrointestinal tract. From there, it is being absorbed into the liver. Okay, that is by the portal circulation. And from the liver, it comes back into the gastrointestinal tract via the bile duct. So this entire process is called as enterohepatic circulation, and because of enterohepatic circulation, the drug is being circulated for a longer duration, so the drug is not actually eliminated completely, and this is the reason why enterohepatic cycling, that is enterohepatic circulation, prolongs the duration of action of the drugs. So this is the reason why oral contraceptive pills efficacy is less in case the individual is having disease of liver, because in that case enterohepatic cycling doesn't occur, and as a result this can lead to failure of the drug. Next is other route of excretion includes pulmonary excretion. So it is mainly for the drugs like general anesthetics and alcohol, which is being exhaled out with the air. Next, drugs can be also excreted via sweat, saliva, and milk. So, if the drug is excreted via milk, it can affect the suckling. That is, if the drugs are having some effect on the neonates, it can be transferred via the milk to the neonates, and this will lead to the adverse effects which can be seen in the babies. Now coming to one entity that is called as clearance. So clearance of the drug is basically defined as the volume of the plasma from which the drug is removed per unit time. Means it is the volume of the plasma which is being cleared of the drug in unit time. So clearance is equal to rate of elimination by the plasma concentration of the drug. So rate of elimination means milligram per minute, and plasma concentration means milligram per ml. So the unit for clearance will be ml per minute, that is volume of the plasma which is being cleared of the drug per unit time. So now we have different kinetics for this clearance. Okay, so first we have first order kinetics, and then we have the zero order kinetics. So in first order kinetics, what happens is a constant fraction of the drug in the body is eliminated per unit time. Suppose we have 100 microgram per ml as the concentration, so after 1 hour it will be converted into 50 microgram per ml, and then after 1 hour it will be converted into its half, that is 25 microgram per ml. So the rate of drug elimination is directly proportional to the plasma concentration, as you can see. So suppose if it was 200 microgram per ml, then it would be converting into 100 microgram per ml. It means 100 microgram is being eliminated, that is cleared out. So here the rate of drug elimination is directly proportional to the plasma concentration, whereas it is just the opposite in case of zero order kinetics. So we will be discussing about the zero order kinetics, and this time which it takes for the concentration of the drug to become half is called as the plasma half-life. Now coming to the zero order kinetics, in this a constant amount of the drug in the body is eliminated per unit time. What was in case of first order kinetics? It was a constant fraction, means a constant fraction of the drug, like half of the drug is being eliminated per unit time, whereas in this amount is the constant. As you can see here, 200 microgram per ml, after 1 hour 10 microgram is removed, then it becomes 190 microgram per ml, then again after 1 hour again 10 microgram is removed, so it converts to 180 microgram per ml. So in every 1 hour there is removal of a constant amount of the drug. So here the rate of elimination is independent of the plasma drug concentration, whether it is 200, whether it is 190, whether it is 180. Every time only 10 microgram will be removed in 1 hour. So this is the speciality of the zero order kinetics. Now drugs like phenytoin and aspirin at low doses, they will follow the first order kinetics, that is constant fraction of the drug is being removed. After some time what happens is this elimination process gets saturated. Okay, the process becomes saturated, and because of this finally the kinetics will change to zero order kinetics, and that is what is called as saturation kinetics. That is from being a first order kinetic elimination to a zero order kinetic elimination. Now plasma half-life. So it is very simple. That is the time which is taken for the plasma concentration of the drug to be reduced to the half of its value. So that is called as plasma half-life. What is the significance of plasma half-life? That is important. It helps us to find out the duration of action of the drug. As we know, by 4 to 5 half-lives, the drug will be completely eliminated from the plasma. So from that we can find out the duration of action of the drug, and also the time which it requires for reaching the steady state concentration, that is at which the rate of administration will be equal to the rate of elimination of the drug. So what is the steady state concentration? So steady state concentration means if a drug is administered repeatedly at short intervals before the complete elimination. The drug accumulates in the body and reaches a steady state at which the rate of elimination equals to the administration. So this is called a steady state plasma concentration or plateau level. As you can see here in this graph, by 4 to 5 half-lives, okay, we have a concentration which is fluctuating over a particular value and it is almost constant. So this is called as the steady state concentration of the drug. Coming to the entity called as loading dose. So what happens in loading dose is that we are giving a single large dose or a series of quickly repeated doses so as to rapidly attain the target concentration. So after this, what we will do is just we will give the maintenance dose so as to balance the rate of elimination and the rate of administration. But there is one disadvantage because of this. Since in loading dose we are giving a high dose of drug suddenly, it can lead to higher concentrations of the drug and finally which can also lead to toxicity. So this is one of the disadvantage of giving the loading dose, but most of the things are having advantage and disadvantage. So advantage is that we attain the therapeutic concentration very easily, and the disadvantage is that there can be chances of toxicity also. So this is about the loading dose. Now coming to the next topic, that is therapeutic drug monitoring. So it is actually a part of pharmacokinetics and it basically means the monitoring of the treatment by measuring the plasma concentration of the drug. So it is applicable only for those drugs where the response of the drugs depends directly on the plasma concentration. Hence it is not applicable for hit and run drugs, because in hit and run drugs, as we know, the drugs will have the effect even if its plasma concentration is zero. So it is not applicable for hit and run drugs. It is applicable only for those drugs where the response is directly proportional to the plasma concentration of that particular drug, and where we are actually not able to measure the effect. For example, like in case of antipsychotic drugs where we are not able to measure the response, there only we are going to do therapeutic drug monitoring. And also in the drugs where we can easily measure the response, like antihypertensive, we can easily measure the response by measuring the blood pressure. Then in case of oral hypoglycemic agents, we can easily measure the response by checking the blood glucose. In that case, there is no use of doing therapeutic drug monitoring. So this is about therapeutic drug monitoring. Now finally coming to the nursing implications. So it includes the following points, that is the knowledge of pharmacokinetics will help in selecting the correct route and the time of administration, and also assess the patient's response to a particular medication. And drugs should be selected carefully in pregnant women because, as we know, in first trimester if we give several drugs, it can cross the placental barrier and this might lead to teratogenic effects in the baby. So drugs has to be given in pregnant women very carefully, and there should be proper monitoring of the drugs also. Next is proper collection of the blood samples is to be done when we are sending the samples for therapeutic drug monitoring, because in that we need several details like when was the last dose of the drug given, like what was the duration of the therapy for which that particular drug was given, what was the indication for doing the therapeutic drug monitoring. So all those has to be provided. So these are some of the nursing implications. First, knowledge of pharmacokinetics to select the route and time of administration. Next, in pregnant women we have to give the drugs very carefully and we have to monitor the patients. And for sending the samples, that is blood samples, for therapeutic drug monitoring, we need to provide the several details like the duration of therapy of the drugs, the last dose of the drug, what is the indication for doing the therapeutic drug monitoring, whether it is to find out whether it is toxicity or whether to check whether the particular concentration of drug which we desire is actually achieved or not. So these are the different nursing implications related to the topic of pharmacokinetics. So with this I would like to end this tutorial. I hope you like this video. So if you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. And with this we will end this presentation. Thank you guys.